Assalamu alaikum. I am Dr. Shaheen Anjum, maxillofacial surgeon at National Institute of Dentistry, Multan, Pakistan, and now I am here again to tell you about the examination of the orthognathic surgery cases. And for the assessment of patient, the first dental visit is very critical, and the patient chief complaint you should address to make the orthodontic prescription, and you should assess what the patient expects from the treatment. And at the first visit you should assess about the medical status of the patient and ask about the history of any drugs taken by the patient. And for in history, very important questioning, you should ask about the functional problems and the speaking difficulty and eating difficulty and any problems with the breathing and the sleep apnea. You should address the joint pains, and you should address the aesthetics of the patient and according to the patient's wishes and motivations. And history of allergies are very important in the treatment of the orthognathic surgery, and you should assess the associated syndromes. You look for the wisdom tooth that should be extracted 6 months prior to the surgery. Ask about the previous surgeries and history of trauma. And these are important, relevant questions that should be asked from the patient of the orthognathic surgery. And positioning of patient is very important in determining the aesthetics and the asymmetries of the patient. And when you position the patient, the Frankfurt plane should be parallel to the floor and the jaw should be in surgical occlusion. And while examination, the clinical examination is performed by proper positioning of the patient, and patient should look straight, and you should assess the shape of the face, that may be long, short or broad, and you should assess the patient in different proportions. And the profile evaluation is done in the lateral and frontal view. And in the lateral view, the horizontal lines that divide the face in 3 equal halves, and the horizontal lines, the first line starts from the hairline, and the second line starts from the glabella or the eyebrow, and the third line from the subnasal, and the fourth line at the inferior or border of the mandible. And there is also subdivision of the lower half of the mandible by the line passing through the upper lip and the lower lip, and the 3 halves should be equal, and this determines the normal vertical relations. And also the lateral view determines the anterior-posterior relationship of the jaws, teeth and the soft tissues, and the 3 halves should be equal, but the subdivision of the lower facial half is done through the lips, and the upper lip should be 1/5, 1/2 of the lower mandibular facial height. Then this is the evaluation of the vertical facial. And then the frontal face view is examined to balance, to check the balance and asymmetries, and there are also vertical lines to determine the proportions of the face that should be equal, and the frontal view should be divided by vertical lines into 5 equal halves, and the 2 lines run from the medial canthal ligament and 2 lines from the lateral canthal ligament, and in the midline the intercanthal distance and the alar base width and chin should be equal, and these halves should be equal to and determine the asymmetries and the facial proportion, alar base width and alar base width, and also the incisal show. Alar base width should be equal to the intercanthal distance. And then we should assess the smile. The incisal show in the relaxed position, it is 1 to 2 millimeter, and then after smiling the patient it is 8 to 10 millimeter. If it is increased, the gummy smile is whether there is gummy smile or the enlarged incisors. and dental midline is also assessed in the frontal profile, and this is the way how occlusal cant can be assessed. And from the lateral profile we should assess the vertical relations, the cervicomental angle and the nasolabial angle and the soft tissue profile, and then start from the inspection. And the basic of assessing the clinical examination of the orthognathic is the to look and inspect all things in 3 dimensions, because we have to rotate the jaws and teeth in 3 dimensions. So we should look into consideration in 3 planes, that are the anterior posterior plane and the vertical plane and the sagittal plane. And in the anterior posterior plane we look for the overjet retroclination of the jaws and the teeth, and in the vertical plane we should look for the long face, short case, which many terminologies that can be spoken. For the long face, that are the dolichofacial or the hyperdivergent, and the hypodivergent face or the scare face is the low angle case. And in case of the vertical plane, there may be the deep bite, open bite, and in case of sagittal plane we look for the cross bite. And while assessing the skeleton you should assess the teeth and soft tissues also. And inspection is started from the extraoral, and extraoral inspection includes the lip competency, and you should check the tone of the muscles and the soft tissues of the cheeks, and look the incisal show while resting position, and while the smiling position, and look the nasolabial angle at the lateral view, and cervicomental angle, antegonal notch, and nasal dorsum width should be equal to the interanteral distance, and also to the subnasal is equal to the nasal dorsum width, and you should look for the asymmetries. And then you should go for the intraoral examination, and intraoral examination you should see the occlusal relationship of the incisors, canine and molars, and the overbite and overjet and crossbite, and you should look for any tooth size discrepancy, any missed, decayed or retained teeth, and periodontal ligament evaluation, any tongue abnormalities, and any impactions, any pathology, and assess the arch form, occlusal cant, symmetry, midline, alignment of the teeth, and also oral hygiene. You should assess the status of the soft and hard tissues and the crowding spacing. And there are 3 curves of Spee, curve of Wilson, and curve of sphere of Monson, that should be assessed to should be evaluated for asymmetries. And this is the curve of Spee, anteroposterior curve that starts from the incisal edge towards the molars, this buccal cusp of the molars, and then goes towards the ascending ramus. And if it is steep, then there is deep bite, and in orthodontics it determines the intrusion or extrusion of incisors. And the curve of Wilson, that passes from right to left the buccal cusp of the molars and the premolars, and it determines the width of the arch and the distal tipping of the molars. And the curve that combines the curve of Spee and curve of Wilson, that is the sphere is formed, that is in 3 dimensions, that is the sphere of Monson. And normal sphere of Monson is 8-inch sphere, and its center is located in the glabella. And after inspection there is a palpation. You should palpate the muscles of the mastication to check the strength and tone, and you should palpate the temporomandibular joint, and assess the position of the condyle, and assess the tenderness over the condyle while opening and closing jaw, to assess any previous TMPDS, and assess the bite forces. And after that, the radiographic examination that includes the panoramic view, lateral ceph, PSF, cone beam CT, and the visual surgical planning. And sphelometric analysis is very important because it determines the spatial relationship between the teeth, jaws, and skull, and it helps in diagnosis of the skeletal and dental problems. It is helpful to track the facial growth patterns, and it guides the orthodontic or surgical treatment and evaluate the changes during and after treatment, and it's also helpful in record keeping. And orthopantomogram is two-dimensional view to show the impacted teeth, missing teeth, and the condition of all teeth, and any pathology, temporomandibular joint status, and the position of mandibular canal in 2 dimensions. And CBCT that determines the position of impacted teeth and ID canal in 3 dimensions, and it determines any asymmetries, and also it is helpful in soft tissue evaluation. And the multi-slice CT scan, it is advised in cases of the complex dysgnathias and the severe asymmetries, and it is also advised when intraoperative navigation is performed because it analyzes changes size, shape, and volume of the osseous structure. It determines the quality of bone and bone deficit in any plane, and position of inferior alveolar nerve, and it determines the width of the cancellous bone between the mandibular canal and buccal cortex, which is average 2.9 millimeter. Visual surgical planning is very important because it is it brings before surgery the jaws in the desired position, and we can see the effects on the soft tissue and candiles, and so the desired effects can be obtained before surgery. We can assess how we can obtain the desired effects, and after this and the keeping in view the patient's consideration, and orthodontic prescription is made, and it is registered, and treatment plan is registered into the CAD/CAM occlusal wafers, and also it helps in positioning of the fixation plates, and drill guidelines are obtained from the visual surgical planning. And soft tissue analysis is also done by the lateral ceph, by the hold-away ratio, S-line, E-lines, and TVS analysis that shows the retroclined or proclined relation incisors and retroclined profile in anteroposterior dimensions in relationship to the subnasal or the chin. And we should assess and consider in 3 dimensions both hard tissue and the soft tissue movements. And TVS analysis, which is the true vertical line through subnasal that is perpendicular to the natural head position, and it is also helpful in determining the anterior posterior soft tissue relationship. And prognosis tracing is also important because it determines the type and amount of incisor movements that are required to correct the increased or decreased avagite, and sometimes there are the dentoalveolar compensations of incisors before surgery that can confuse the treatment planning. So the prognosis tracing is done to mimic the movements that are achieved with different treatment approaches to help determine the best course of action for that patient. And then we should go for the dental model analysis, and the dental model analysis registers the occlusal bite, and by taking the face bow and after splint fabrication we can prescribe the orthodontic details and transfer these details to the patient. And we should assess the growth pattern of the patient before going to surgery, and that can be assessed by 4 methods, that is the cervicovertebral maturation staging that includes the 6 stages, and the deep cavities at the inferior border of the mandible, and by the hand wrist x-rays, and the serial ceph at 6 months apart. And We should analyze airway by the upper pharyngeal space and the lower pharyngeal space in the radiographs. And the upper pharyngeal space is the distance between the soft palate and the pharyngeal wall, and it is almost 15 to 20 millimeter. And the lower pharyngeal space is the perpendicular distance from the posterior border of the tongue to the inferior border of the mandible, and it is 11 to 14 millimeter. And then the timing of the treatment is very important, and in mostly in case of females it is 15 to 16 years of age, and in case of males it is 17 to 18 years of age. And then we should go for the treatment planning, and there are different phases of treatment planning. In the phase 1 we should synthesize the problem list, assess the data and the diagnose. And then in the phase 2 we should discuss the problem with the multidisciplinary approach and determine a tentative treatment plan. And in phase 3 is the preparative stage, in which we should prepare before surgery the restorative treatment of tooth, and the endodontics should be performed, periodontics should be performed, and re-evaluate. And then there is a maintenance phase, and periodontal evaluation and restorative consideration should be done before surgery, and after that pre-surgical orthodontics is done. And treatment timing is very important. And then we should articulate on the stone models. And in phase 1 there is scaling, filling of the carious tooth, and the periodontal problems should be assessed. And the final treatment planning is followed by the first phase of the treatment plan. And in this final treatment planning there should be re-examination of the facial structures, and from the photographs, models and radiographs, and prediction tracings and model surgery. After these all methods, the re-evaluation is done. And model surgery requires three-dimensional consideration, and it is the final treatment, that is prescription, and it is based on the all diagnostic informations, and the sprint is made from the model surgery that guides the surgeon to avoid bad splits, bad surgery. And model surgery needs to correct open bite, mandibular setback, and occlusal cant is corrected, and occlusal level plane is maintained, and movements are on the model should be based on the prediction testing and the clinical evaluation. And we should, while choosing the surgical treatment plan, we should consider the three-dimensional consideration. And during surgery we should perform the all rotational movement of the jaws and teeth in 3 dimensions, and the rotating movement in 3 dimensions is performed in in 1 dimension. When they from the anterior posterior, the rotatory movement is called the roll, and occlusal cant is rotated in that roll method. And from the horizontal line of axis, the rotation is called the pitch, and the occlusal plane is rotated during surgery in this axis, and along the vertical axis the rotation is called the yaw, and the arch is rotated in this manner, in the yaw manner. And after that surgery, we should consider the post-surgical detailing of the occlusion, root paralleling, and after surgery the post-orthodontist is done. Vertical elastic extractions should be performed in case if any deep bite is retained. And to prevent the relapse, the 2 muscles are the cause of the relapse. The medial pterygoid and pterygomasseteric sling is if it is bulky, it is responsible for relapse. And if assessed before surgery and myotomies are done, and fibers should be cut, slings should be cut to prevent the relapse. And thank you very much. That is the end of presentation.